Moving on to the next topic about laboratory interpretation of CBC and TFT, as Pankaj sir just told us about the first doubt that goes is on the pathology reports. So now I would like to call upon the chairpersons for the next session. Firstly, Professor Dr. Vatsala Mishra ma'am. Ma'am is HOD Department of Pathology and Dean Academics at Evelyn Medical College, Prayagraj. We welcome you, ma'am. Dr. Jyotima Agarwal, ma'am. Ma'am is a senior pathologist at Prayagraj and director of Cytocare Pathology Labs. We welcome you, ma'am. Dr. Sanjeev Yadav, sir. He is a senior consultant physician at Corwin Hospital. And Dr. Neeta Verma, ma'am, who is a senior practicing gynecologist at Saket Hospital, Prayagraj.
All the chairpersons are here, so now we can start the session. I would like to invite the speaker, Dr. Apurv Ghosh. He is a young and upcoming and brilliant pathologist from Allahabad. He did his education completed from Allahabad, that is St. Joseph's College. He did his MBBS from Netaji Subhash Chandra Bose Subharati Medical College, Meerut, and MD Pathology from Kasturba Medical College, Bangalore. He is the gold medalist in MBBS of Zanjaili, first prize winner at PG quiz held at Father Miller Medical College, Bangalore, and fellow of Academy of General Education with certificate. He has several publications to his credit, and he has done several presentations in various national, state level conferences. So I welcome you, Apurv, here for presentation. Thank you, ma'am.
Good evening, everyone. Respected chairpersons, members of the audience, and friends. So my topic is interpretation of CBC and thyroid function tests, case-based scenario. Cases have been wonderfully discussed in the earlier presentations. I'll be going through them quickly, briefly, and I'll be talking more on the CBC associated with thyroid dysfunction. So this would be the overview of my presentation. I would start with the introduction, the cases, then the thyroid dysfunction with the hematological changes that are seen, the changes that are seen specifically to hypothyroidism and hyperthyroidism, the pathophysiology associated with it, and I'll conclude my talk. So thyroid hormone plays a crucial role in metabolism and proliferation of blood cells. That is fairly known. It involves regulation of the body growth and the development and maturation of hematopoietic stem cells and its maturation. The different aspects in the course of thyroid hormone dysregulation include anemia, erythrocytosis, leukopenia, thrombocytopenia, and in rare cases, thrombocytopenia. The CBC parameters that are fairly altered include MCV, MCH, MCHC, and RDW. Other parameters are also considered that I'll be going through in later stages of my talk. So I'll rush through these cases briefly. These are classic cases with hypothyroidism, some with subclinical hypothyroidism or with hyperthyroidism. The thing to note is the values the values with regard to anemia, the hemoglobin, the hematocrit or the packed cell volume, the MCV, and RDW. Those things are to note because they give the clue of what type of anemia or what type of hematological dysfunction we are facing with. So again, classic cases of hypothyroidism with different presenting features. Here again, the hemoglobin is fairly normal, although the WHO categorizes anemia with hemoglobin less than 12. So fair to say that this patient is having a sense of anemia. The MCV is to note and the RDW. A patient with hyperthyroidism, again, things to note are the hemoglobin, the MCV, and the RDW. These parameters are important because, like I said, I'll be going through them later in the later part of the talk. So again, same features, the textbook approach to hypothyroidism where it has been discussed very wonderfully by the early speakers. So I'll just skip through them where we see the measurement of TSH with the unbound or free T4 and how it fits into the diagnostic category of hypothyroidism with Hashimoto's or with iodine deficiency, etc. Or with hyperthyroidism, whether it's Graves or an autoimmune associated thyroid dysfunction. So the CBC parameters that are to note are the hematocrit, MCV, MCH, like I said, RDW. A newer parameter which is being utilized is the neutrophil to lymphocyte ratio, where the neutrophils are divided by the lymphocytes, circulating lymphocytes, the absolute count, and we get a value. These are considered for systemic inflammatory states, and it's being considered in Graves. And platelet to lymphocyte ratio, again, in patients with an inflammatory condition, there they are being evaluated. So NLR are of utility in Graves' disease, where the lymphocytes are hypothesized to proliferate more and cause destruction of the thyroid gland. So again, the definition, I'll skip through it. The thing to note is the way we measure hematocrit. In the modern analyzers, the hematocrit, it is measured through a single RBC total count versus the number of the volume of the size of the cell. So in the modern analyzers, the hematocrit is measured by the number of cells and the size of the RBCs, while traditionally it was measured by centrifuging the sample. So while centrifuging the sample, whenever the plasma packs in more cell volume, it would give a spurious result. So in thyroid patients, there might be macrocytosis, which would pack more plasma volume and would result in an abnormal or spurious result. So that is a point to note. Again, MCV and MCH, MCHC, they give us the average size of the cell. It is descriptive, gives whether the anemia is microcytic, normocytic, macrocytic. In thyroid patients, mostly hypothyroid patients with hypothyroidism, we see macrocytic blood picture, and that will move to a later point and we'll discuss about that. RDW is an important parameter which is being evaluated for patients with thyroid dysfunction. It is usually increased. It gives a sense of various shapes and sizes of the RBC which is in circulation, and it is mostly seen in patients with hypothyroidism. So moving on to the next part of the talk, the most common hematological changes that we face in thyroid patients is anemia, where it is observed that 20 to 60% have anemia. It is more common in men than in women, although hypothyroidism on a whole is more common in women, but the anemia per se would be more common in men with suffering from hypothyroidism. In subclinical hypothyroid patients, anemia is present in 39 patients. In hyperthyroid patients, anemia is usually mild and it is usually found in 10 to 25% of the patients. WBC and platelet parameters are less frequently affected in patients with thyroid dysfunction. There are some notable changes that are coming up with regards to the lymphocyte count, the NLR, and other platelet parameters such as the platelet lymphocyte ratio and the mean platelet volume, which is still under investigation. So this is a very busy slide just to show that patients with primary hypothyroidism, they have a lower MCV than euthyroid patients, and that is statistically significant. Although this is not in the category of calling it anemic or microcytic, but there is an association which shows that MCV is lower than in euthyroid patients. Similarly, with anemia, patients with hypothyroidism show a hemoglobin concentration of around 10 in this study, which was done by Bashir et al. And it was found to be significant, statistically significant. Another study done by Mishra et al., they also saw that in patients with subclinical hypothyroidism, the MCV was not affected, was not statistically significant, but the hemoglobin was lower in the subclinical hypothyroid patients, and other parameters just suggest that there was hypothyroidism in process. So in another study by Jafar et al., here we see that the three groups of patients where the counts are low in between euthyroid and hypothyroid patient, although not significantly low to indicate of anemia, but still they are on the lower side, which is statistically significant. In patients with hyperthyroidism, in this study they found that the MCV is low as compared to the euthyroid patient, and it was statistically significant. Another, in the same study, it was noted that eosinophils were seen more in patients with hypothyroid than in patients with hyperthyroid as compared to euthyroid patients. It was not statistically significant, but it was noted in the study. So hypothyroidism and hematological changes. What are the changes that we see? The changes that we see may be normocytic, normochromic, microcytic, hyperchromic, or macrocytic. So the entire spectrum of anemia is seen in patients with hypothyroidism. The microcytic hyperchromic anemia associated with hypothyroidism should be considered as iron deficiency anemia until proven otherwise. Although the anemia in hypothyroid patients can be due to not only because of the hormone, but also due to other symptomological presentations such as menorrhagia or poor oral intake, etc. Patients with hypothyroidism also may have vitamin B12 or folic acid deficiency and may present with macrocytic anemia. In patients with Hashimoto's thyroiditis, a lower NLR or neutrophilic lymphocytic ratio was seen, as well as platelet lymphocytic ratio. So in a study by Apurv et al., they found that lymphocytes were more in patients with Hashimoto's thyroiditis than in normal patients. It was statistically significant. The NLR was higher as compared to the controls. It was also statistically significant. Again, in this slide,
all this should always examine the peripheral smear of CBC cases just to see if there are any platelet clumps or any abnormalities in the WBCs or RBCs, which can only be resolved by careful examination of peripheral smear. So that is all. Thank you very much, Dr.
Thank you,
Apurv.
ma'am.
And now any questions if there are, please come forward.
I will again like to add comment which I have said several times, that sample collection is the most important part of any test. Pre-analytical errors are more than 90% if you get a wrong result. So just see how the samples are collected, because each and every test has specific methods. Like all the coagulation tests, like D-dimer, जो कभी COVID के समय में every patient was having D-dimer, and what we realized doing in our lab, that if the ratio is not proper, blood and anticoagulant, like we know that in citrate vial, the ratio of blood which is written on the vacuum that should be maintained. If it is not maintained, you will get erroneous results. Then how the samples are mixed, that is again very important. In your hospital, the technician will take the sample and will vigorously shake it, mix kar rahe hain. It may affect the cell morphology and then the results. And again, the accuracy of sample. If you prick the needle for collecting a sample and you take longer time, platelets will always be less. जो कि usually जो हम लोग देखते हैं कि platelet कम हो गई, many of them are falsely low, because as soon as you prick a needle, insert a needle in a vein, the platelets will start clumping there immediately. And if you take a longer time in collecting the sample, the platelet count will come less, because platelets are clotting at the site of puncture. So instead of saying that these reports are not coming, and usually people want, because this is a common general practitioners here, so I am taking these points, that ये report मेरे हिसाब से नहीं है. अभी इसके पहले जो डॉक्टर पंकज his lecture he stressed that we are giving you a report by a machine. Machine will read whatever it gets. There we based on the chromatography. The results are based on the measurement of sizes when it is passing through a hole. If it is a giant platelet, it will be counted in the RBC. If RBC is fragmented, it will be counted in the platelets. So sample collection, so always when you get your reports, try to correlate with clinical finding. Try to treat the patient as per the reports and along with correlation with the clinical sign and symptoms. Never try to treat the patient on the basis of a single report which is generated by a machine. Though we put the quality control, and I think in every lab the quality control should be done every morning for these machines, and most of the pathologists they do it, but still clinical correlation is very, very important, and many a time we ask for the clinical correlation so that we can interpret, and you have to interpret that. So remember, the error starts at the time of sample collection. You all can blame that this pathologist, two labs are, it is a very common practice that if you don't get a satisfactory result as per your, you can say diagnosis, you send it to another lab. And then you say that two labs have different reports. The two labs may have a different methods which they have different control values and normal values. The two labs may have different samples. So if you want to repeat any result, give that sample. Only send that sample back only. Usme bhi because of that time lapse, as Jyotima said, that changes may be there. So always interpret the results with the clinical correlation. That thing was, I was really impressed, and I say thank you Dr. Pankaj. He has very, very stressed that we have to see. As he was showing that same result from the lab, same result from the lab. But different scenario was there, and then we have to see those scenarios. So that is very important. And thyroid changes are there because depending upon the hormone, the metabolism is changed, and we can get change in the CBC counts. as has been stressed by Dr. Apurv. Well presented, Apurv. Thank you.
Thank you, ma'am.
Thank you, Dr. Apurv. I now request Sujit Singh sir to kindly come on the stage and honor the speaker and the chairpersons. Thank you.
I now request her to kindly give the certificate to chairpersons.